Hey, Maya.
Hi.
I wasn't sure if people would show up early or not, so I just got in here. Um, the Zoom doesn't let me do like 45 minutes. It makes it be like a half hour or on the hour, so I had to say 10:30. Let's see. See if I can get where I want here. So Maya, I fixed the addendum and I put it back on Canvas here, so it should be correct now.
Okay.
So there was that big chart that I had on there. There's like conflicting stuff all over the place on what you're supposed to do with ATI. So I had the wrong thing on there. So I got rid of it. I found the right thing. So you guys should be good now. And it was like 3, 7, or 12 templates, depending on your percentage. So.
Okay.
Hey, Kylie.
Hi.
Just waiting for a couple other people to show and then we'll get started. Do you guys have a physical book of this or do you have an online version?
We have an online version.
Oh, that stinks.
Also, I don't have the med math book. It expired and disappeared.
Okay. I'll email someone about that today to see what we can do with that.
Thank you.
I can probably, you know what I could do? I'll just make a copy of that page I was telling you guys about and I'll scan it and I'll send it to you guys so you have it to do.
Thank you.
Is everyone else in the same boat with that too?
I know I am.
Okay.
Yeah, I am as well.
Okay. That's so stupid. Why would that expire? It doesn't make sense why that would expire.
So after I took that practice math exam, it doesn't let me see the results or access it again.
Yeah, I was just gonna say that also.
Oh, well, here, I might be able to show you real quick. Let me stop
Like I can't
sharing
go back
this.
to practice.
Hold on. So I have to, actually, I guess it does. Yeah, let me just fix this. So under settings, there's a thing that I can flip over so you guys can see your answers and stuff. Go back there now and see if you can see anything. And I also just flipped over a thing that says allow multiple attempts.
Yeah, it lets you see
Okay.
it and access it again.
Okay, perfect. Yeah, for this one, I don't care because it's just a practice one, so that's fine that we leave it like that. Yeah, I didn't even think of it. I had to change that. I'm sorry about that. There we go. Okay, I don't know if everyone else is going to show or not. So it looks like it's about 10:44 my time. You guys see the same time?
Yeah.
Yeah.
All right, I'm just going to start then. Heck with it. Okay, so the first one we're going to go through is this chapter 1. So it gets into, some of the learning outcomes first on this one slide here. So we're looking at current trends in the management of labor and birth. We're talking about trends in maternal and infant health outcomes. We're looking at leading causes of infant death. We're looking at current maternal and infant health issues, and then also identifying primary maternal and infant goals for Healthy People 2020. So as far as trends in the care of childbearing family, really, we've come a long way over the years. So years ago, like say you had a baby that was born premature, like maybe, I don't know, 32 weeks or something. So years ago, if you had a baby that was premature like that, you wouldn't be able to do a whole lot for that baby, and they maybe wouldn't be able to survive, you know? But now we've come so far that babies who are 25 weeks can survive even, you know, because we have all of the stuff that we do now.
Oh,
So it's a lot different than it used to be. Other things that this mentions here, it talks about baby-friendly hospitals and also the Safe to Sleep initiative. So what is a baby-friendly hospital? So what this means is you have a certain policy about breastfeeding. And it doesn't necessarily just have to be hospitals. It could be other places too. Like for instance, at our school, we have a policy about breastfeeding at our school. So if someone needs to breastfeed, we have to be able to provide them a place to do that and, you know, give them, you know, privacy and all that kind of stuff. So here with hospitals, they say we want to train all healthcare staff about this. We want to encourage breastfeeding as much as we can, so train all moms about this. We want moms to breastfeed within 1 hour of birth. We want to show moms how to maintain lactation.
what?
We want to give infants no other nutrition other than breast milk because they benefit more from breast milk than anything. Practice rooming in. This means that the baby can stay with the mother in their room like all night if you want to. You can breastfeed the baby on demand, and do not give pacifiers, which I gave all my kids pacifiers, so whatever, you know. Foster establishment of support groups for moms as well. So a lot of times mothers will get really frustrated with breastfeeding because they don't understand what they're doing wrong, and they don't have that support to help them with it. So then they give it up really quickly. So if you have support groups that people are in, sometimes that'll encourage people to stick with it for longer. So remember, I got these PowerPoints from the lady in Wisconsin, so that's why she has all this Wisconsin stuff here. So she has all these hospitals listed there that do that baby-friendly stuff. The other thing that mentioned a little bit a couple slides ago was the Back to Sleep campaign. So again, we've come a long way over the years with what we know. Years ago, we used to say, oh, put your baby on their belly. You know, when you put your baby to sleep, put them on their belly. That's the best thing for them. Well, now we know that's not the case. We want to put all babies on their backs because of the incidence of sudden infant death syndrome. We used to put, 3 million stuffed animals in their beds, and we used to have the bumpers all around the crib and all of these things that could really, cause problems with this baby, but we didn't know any better, so we did all of that. So this slide is just showing how now, since we know about this, the trend of sudden infant death is going down, So because we get, babies to sleep on their back, that's a really good thing. It's helping a lot. Okay, so then this gets into a little bit about preterm births. So, 40 weeks gestation should be, hey, this is a healthy baby, 40 weeks. So if you're very premature, this means that you're less than 32 weeks. So you're really early on. Moderately premature would be 32 to 33 weeks. And then late premature would be 34 to 36 weeks. So the total US preterm birth rate in 2016 was 9.85%. So we still had, some preterm births, but not too bad, I guess. So this picture here is showing you a newborn that's less than 32 weeks. So as you can see, this baby is tiny as all get out. They have no fat on them whatsoever, which they need that fat because they'll be healthier with that fat. And you see, according to this person's hand here, how tiny they are compared to this person's hand, right? And I don't know if you notice on their one arm, they have like what looks like a bracelet in a way. It's the mom's wedding ring that's on this kid's arm. So that shows you how tiny and little this baby is. This baby cannot breathe on its own, so they're on a ventilator. So they are intubated, and this is the ventilator here. And then they also have a feeding tube in because they need some nutrition. So this kid has a long ways to go before they're able to get out of the NICU. At 33 weeks, you're a little bit better off, but you're still pretty tiny. So you maybe have a teeny bit more fat on you. But see, as you can see, this person still is on a ventilator. They're still having a feeding tube. They're still really tiny. And then look at this, 35 weeks. So this person is a lot healthier compared to those other two babies we just looked at. So they have a lot more fat on them. And the whole thing with the fat, if you have all this fat on you, it helps you keep your temperature. So babies, when they are born, they have a hard time maintaining a decent temperature. And so if you have all this extra fat on you, that helps you to be able to maintain that. So that's why these guys look a little bit healthier, and they're not hooked up to all the stuff like the other ones were. Because now at 35 weeks, I have, formed lungs that can actually breathe and do what they're supposed to do. And, you can actually feed them, like a normal way. Okay, so complications of preterm births. So this is the leading global cause of death under age 5. So long-term effects of preterm birth. So if you are born premature, you can have respiratory disorders. You can have cerebral palsy. You can have vision and hearing disorders. And you can also have developmental delays. Okay, so this is talking about birth weights. So obviously, the higher your birth weight, the better off you're going to do. So especially like normal birth weight, this is where we want everyone to be, okay? So if I'm underweight, I'm going to tend to have some of those problems like we were just talking about with complications. And then kids that are overweight, what do you think you would see with them? So I'm sure you all know, like if someone has diabetes and they have a really big baby, their baby is going to be at risk for diabetes as well, right? So that's going to be one thing that we're concerned about. And also they're going to have problems with their weight as they get older as well. So that's going to be a couple of things that we're going to be concerned about with high birth weights. So the weight of a newborn is an important predictor of the future of morbidity and mortality. So very low weight birth, babies are 100 times more likely to die in their first year of life than those that have birth weights greater than 2,500 grams. So this is a big, public health thing that we try to focus on to, fix that. So we don't have too many babies that are born that way that are going to die unwittingly. All right, so when we talk about infant mortality, this is deaths before their first birthday. So U.S. infant mortality rates are 5.8 per 1,000 live births, and this was a figure from 2019. Here's a graph kind of showing this, comparing us to other countries, which this is kind of interesting to me. So this is from 2014. And you would think, since the United States is so far advanced compared to a lot of other countries, that we wouldn't have such an issue with this. But look at this. We are top in infant mortality compared to all these other countries. So look at Japan. Japan's doing really good, 2.1 compared to our 5.8. So it seems like we should be learning something from some of these other countries. Here's another one. This is infant mortality per race. So Asian and Pacific Islander infants only have 3.4 infant mortality rates compared to 11.4 with African American babies. So there's a huge disparity here. So that would be another thing that we need to focus on to get that better. Okay, what are the leading causes of infant mortality in the United States? What do you guys think?
C.
Okay, you're right. So pretty much all of those things can kind of contribute to this, but C is going to be the one that's the best answer here. So congenital malformations and chromosomal abnormalities. So, you know, like people who have, you know, Down syndrome and things along those lines, that would be kind of what we're talking about here. Okay, so with maternal mortality, so the World Health Organization wants to focus on that as well. So we need to look at, you know, different types of maternal mortality, what happens with that, and the rate of change in the United States. All right, so in this slide, this is talking about some things that can affect maternal mortality. So when you think about a mother when they're having their baby, some of the things you might think about would be hemorrhage. You know, maybe they have a problem with bleeding after they have the baby and they can't get the bleeding to stop. That would be a big thing. And you see that says 27% there. So that's a big deal. Embolism is another thing. So maybe they get a blood clot that, you know, breaks off and lodges somewhere. So that could be something. Hypertension is another big one. So there's a lot of mothers out there who have a problem with their blood pressure, and you know, people have to be on all these medicines and stuff to control that. So that's a big deal. Sepsis is another one. So if you get sick during pregnancy and you end up having sepsis, that's a big problem. Abortion. So if you get an abortion, a lot of complications can happen from that. So that can, you know, cause you to have a problem. And then there's other, you know, things that they have listed there that are just grouped under other. Also, with Hispanics, whites, and blacks, look at that. You know, so that's another big deal. So maternal mortality rate in Black women is way more than it is in other races. So that's something that we need to focus on to get that better. Okay, so this gets into a little bit about teen pregnancies and stuff along those lines. So the US teen pregnancy rate is kind of not the greatest. And it used to be years ago, this was super high compared to what it is now. I think it's a little bit better now. But, you know, you can have all kinds of problems if you have a teen mother, especially if they're not able to take care of their baby and they have to rely on other people to help them out. According to this here, the United States has more teen pregnancies than all these other countries. And I think this is from 2012. So this is a little bit of an old statistic, but 29.4% compared to 4.4 in Denmark, you know? So this is, so this must be from that lady, she probably put this on here. So this is specific to Wisconsin, but she says Milwaukee has been trying to do certain things to cut down teen pregnancies. So it looks like from 2006 to 2015, whatever they're doing is helping because it's cut it down quite a bit. Here's teenage pregnancy by race. So the biggest one here is Hispanics, it looks like. So that would be something that needs to be focused on to get that better. Other issues, according to teen pregnancy, you know, if you have a teenager who is pregnant, a lot of them have the idea that they're invincible, that nothing they do is going to hurt them, or they don't have that idea that they have another human being that is inside of them that they're taking care of, that they need to consider as well. So a lot of them will be addicted to different things like, smoking or e-cigarettes or whatnot. So especially the e-cigarettes, that's a big deal right now. That's a huge problem. So with smoking, that can be a big problem with pregnancy. So um, this reduces the unborn baby's blood oxygen supply. It can lead to an underdeveloped baby. They can be underweight. They can have heart defects. Their lungs aren't going to work like they should. They can have messed up brain function, and it can even cause them death. So this is a huge deal. And she has this other thing on here about e-cigarettes and pregnancy. If anyone ever asks if it's okay if they can smoke during pregnancy, it's just not a good idea. That should be something that they need to just stop right then and there. And I know it's hard for people, but it can really cause a lot of issues. And I don't think everything is really known specifically about like how much, you can smoke or drink or do whatever during your pregnancy, on how much of that really affects the baby, So you can't just say, oh, I only do 1 or 2 cigarettes a day or whatever, and that's not going to hurt anything, because you don't know the specific amount that it causes these problems with. The next thing in here she talks about is substance abuse in pregnancy. So, when you have mothers who drink, so you get babies that have fetal alcohol syndrome. And then also, mothers who do illegal drugs like cocaine and marijuana, they're going to have similar issues as the baby would who has fetal alcohol syndrome. So in this picture she has here, it shows you that they actually look a little bit different. So they have a low nasal bridge. They have minor ear abnormalities, so their ears aren't going to look quite right. Their upper lip is going to be really thin. So just a lot of different looks about their face are going to be different. And then when this mother does have her baby, you're going to see some things that the baby does that you're going to have to be aware of and try it. And what am I trying to say? Not really try to control, but try to fix. So like this baby is going to have a high-pitched cry. They're going to be super irritable. They can have seizures. They have a hard time sleeping. They may sneeze a lot. As far as like eating, they may have a hard time because their sucking ability is just different. They say it has an excessive suck. They do a lot of sweating. They have tachypnea, hypertension, tachycardia. They can have vomiting, excessive weight loss, diarrhea, tremors. Poor thing. Can you imagine all of these things happening to this baby just because of what their mother did? Okay, so another thing that this mentions is some other issues with pregnancy. If the mom is obese, so this means they have a BMI greater than 30. So for the mother, it means that they could be at risk for gestational diabetes. They can have hypertension. They can have DVTs, wound infections, anesthesia complications, sleep apnea. So that's just for the mother. But then for the infant, you can have heart defects, you can have spinal bifida, birth injuries, childhood obesity and diabetes, all these things. So there's quite a bit of things that can happen just as a result of being obese. So that's something that we need to address with mothers as well. What maternal health conditions are associated with maternal obesity? So it would be all of these things. All right, so when we look at Healthy People 2020, they always are looking at different things that would help us not have a good quality of life, right? So we look at those things because they're problems, and if we fix them, then it helps us increase quality of life for everyone. So infant mortality and health disparities, those are things that we need to focus on to fix so that everyone can be healthier and have a better quality of life. So as a summary here, maternal and newborn care has evolved over time, which is good. And US rates are better than the global average, but they still lag behind in other developed nations. So we need to fix that in some of those areas, definitely. So feel free to listen to all of these comments that she made on here, because you know this lady that I got this stuff from, she's an actual midwife, so she's pretty knowledgeable about all this stuff. All right, and then let me find the second one here. Okay, so this is the second chapter, so we'll go ahead and get into that a little bit. So this talks about ethics and standards of practice issues. So in here, we want to look at any kind of ethical issues in maternity nursing, explore standards of practice in maternity nursing, describe legal issues, and analyze concepts related to evidence-based practice. Okay. All right, so maternity care is a unique area of ethics. So if you think about it, when someone is pregnant, there's a lot of different, ethical things that can come up that you need to be aware of and need to know how to handle. So as a nurse, whether you're in maternity or anything else, you would always go to your ANA Code of Ethics to help you make decisions, because the American Nurses Association, they have everything spelled out there, and it helps you to make better decisions about these things. There is also something called A1. So A1 is, here, let me see if I can find my other slide here. Okay, so A1 is the Association of Women's Health Obstetric and Neonatal Nurses. So this is a great place to come if you need to figure out how to, like their stance on things, because it can help you make a better decision. Like you see, they have all these position statements here about different things. So hey, here's their position statement about breastfeeding, elective induction of labor, fetal heart monitoring, gender bias in women's health. There's all these different things. So this would be another great resource to come to if you had to make a certain, ethical decision about something. Sorry, I'm just flipping screens again. There we go. And then also we're going to look at evidence-based practice too. So if we know that there's good science out there about certain things, we're going to use that to help us make a good decision because it's proven. So those are some of the things that we would do to help us make a good decision. And then, this again talks about the ANA Code of Ethics, which I'll show you here in a second, the piece of it. And then we have ethical principles that we have to follow. And there's different types of ethical approaches that you could use to help you make a decision, which I'll show you on the next slides here. So with the American Nurses Association, this is part of the Code of Ethics. It's bigger than this. But like, this talks about the nurse provides services with respect for human dignity and uniqueness of the client, unrestricted by considerations of social or economic status, personal attributes, or nature of health problems. So pretty much we provide service to everyone, right? And then it talks about safeguards and client's right to privacy, safeguard the client public when healthcare and safety are affected by the incompetent, unethical, or illegal practice of any person. The nurse assumes responsibility and accountability for individual nursing judgments and actions, and the nurse maintains competence in nursing. So that's kind of an important one. We need to, even after you graduate, you have to maintain your competence in what you're doing. So you constantly have to be learning and staying up on the latest of everything to be able to be an effective nurse. In your notes, you guys, I would totally know this slide because this is going to be something that you're tested on. So that A1, that organization I was telling you about, these are some quality measures that they focus on. So they focus on triage, spontaneous pushing, immediate skin-to-skin contact, uninterrupted skin-to-skin contact, eliminate supplemental breastfed infants, breast milk for NICU infants, initiate contact with parents of transferred infants, perinatal grief support, continuous labor support, and then freedom of movement during labor. So meaning that you don't have to sit in your bed the whole time. You can actually get up and, sit on one of those labor balls or do whatever you need to do. So that's a super important part of this. Okay, and then back a couple slides, it said we use ethical principles to help us make decisions about some of these things. So going back to probably funds, we talk about, these different parts of ethical decision making. So these things you definitely need to know. So beneficence. So this is the obligation to do good. So it's an action that promotes good for others without any self-interest for yourself. Non-malfeasance is your commitment to do no harm. Fidelity is being accountable and loyal to your commitments. So if you say you're going to do something, follow through and do what you say you're going to do. That's fidelity. Veracity is being truthful. It's a commitment to tell the truth at all times. Autonomy is the right to make your own decisions. And this is also even when those decisions might not be in that person's best interest. And then justice is fairness in care delivery and the use of resources. So remember a few slides back, we said there's a couple of different approaches that you could use when you're trying to make an ethical decision. And these are those different types of approaches. So you could do utilitarianism. This distributes resources to produce the greatest good for the most people. Or you could do libertarianism, which is where some people are more valuable to society and need to be given more resources. Or you could do egalitarianism, which distributes resources according to need. So you would only give things to people who need it. Okay, so this gets into a little bit about ethical dilemmas. So you have obligations and duties to both the mother and the baby as a nurse. So some of the dilemmas that we might come into contact with would be things like this. Which partner has ownership over embryos? So like maybe you have a mother and a father who aren't married or something, but they both are fighting over their embryos that they have saved. So who has ownership over those? That could be something. Should a child be told about donors or surrogates? That could be another ethical dilemma. Are there parental rights for sperm donors? That could be another one. Does a fertility donor have a financial obligation? And then also, what happens to any surplus embryos? So like if you're saving embryos or something, what happens to ones that you don't want to save? Like say you only want to save 3 or something and you have more than that. Or maybe you only save 1 and you have 2 or 3. What happens to the other ones? So those would be some things that you might have to, figure out. So a lot of times when we have a dilemma like this, it causes a lot of moral distress for people. So not only the nurse, but also everyone else that's involved. So I don't know if you remember talking about this way back, but anytime you have to make an ethical decision, you don't want to make like just a snap decision about anything. You want to think about it really good because you want to know everyone's side, so listen to each person's side and then make sure that you're doing the best for both the mother and the baby. So if you ever have a hard time making a decision like this, you would always go to your ethical board at your hospital. They can help you with this. And then again, like you don't want your own views of something to taint what you do. So like say this has to do with abortion or something and you don't believe in abortion, then you wouldn't want to let your decision about what's best for everyone taint that because of what you believe, if that makes sense. Okay, so this also talks about our ethics in neonatal care. So when we're taking care of a baby. So we have certain ethical obligations to that baby and we want to do no harm here, right? So we need to have a minimal level of practice that's a reasonably prudent nurse is expected to provide, and that's going to be our standard of care that we do. So we need to be truthful with parents at all times with what's going on and, respect parents' decisions, even if we might not agree with something they're doing. And also facilitate communication between everyone and try to come up with a compromise for everyone, do some collaboration. Okay, with these ethical decision-making models, there's this one in particular, this Johnson model that they talk about, where you look at the client's preferences, the medical and clinical indications, the contextual features of the problem, and then quality of life, and then that helps you make your decision. So that's another thing that you could do to help you come to a decision about what to do about something. So what is the name of the ethical duty to do no harm? So this is going to be that non-malfeasance. So this means that we have an obligation to do no harm to either the woman or the baby. All right, this also gets into a little bit about nurses' rights and responsibilities. That organization, that AWHONN, they support nurses' rights big time. And there's a federal law out there that says they have a right to refuse to assist in certain situations. AWHONN has core values. They have this CARING acronym. So this is what it stands for: commitment to the profession, accountability, respect for diversity, integrity in personal and professional behavior, nursing excellence, and generation of knowledge. So that's kind of what they stand for. And then they also have certain standards of research and clinical practice too. So if you really got into their website and looked at it, you would see, some of the things that they do as far as research and clinical practice goes. And there's a box, I guess, in your book, box 2-2, that you could look at that talks more about this. All right, so believe it or not, out of all of the different areas of nursing, OB nursing is the one that has the most lawsuits, I guess you could say. So it's unfortunate, but it's true. So if you ever are thinking about going into this, which is fine if you do, but just be aware that you can end up in a lot of different weird situations here. So evidence-based practice is the gold standard. So problem areas include clinical judgment, communication, and collaboration. So some of the things that cause people to, be in a problem with malpractice would be miscommunication. So maybe there's some kind of high-risk birth and someone said something to someone else and they misinterpreted it and did something wrong. So that could be malpractice. Or maybe you had a technical error, like you were supposed to, I don't know, use some kind of device to help get the baby out during the birth and you did it wrong. And so you caused, a problem. Or they have inadequate documentation. So maybe you're not saying enough in what you're charting. Administrative failures, and then also ineffective supervision. So maybe you have a new nurse who's only been an OB for a short time doing something and she really isn't being supervised well enough. And that's causing them to have malpractice. Okay, another big thing that is a problem with this is fetal heart rate monitoring. So it's super important to be able to assess this correctly. And so this would be another reason why maybe you would have a malpractice issue, because someone doesn't assess it right. You need to be able to have a safe and effective fetal heart rate assessment done. And any kind of issue that may be coming about, you need to be able to identify that and act on it quickly so that the mother and the baby can both be safe. Some of the things that they, say that, is a kind of an issue would be failure to accurately assess. So maybe someone doesn't assess someone completely. Failure to identify deteriorating fetal status. So you should be able to see that on a fetal heart monitor. If someone's going into distress, that should be something you'd be able to tell. Failure to treat poor tracings. Failure to reduce or discontinue oxytocin. Failure to correctly communicate status to the care provider. And then also failure to institute the chain of command. So anyway, evidence-based practice is something that we, use all the time in practice. So here's some different ways that you can, see what the best practices are out there about different things. You can go to the Cochrane reviews and look at that. There's something called the National Guideline Clearinghouse that puts out these position statements about different things every so often that you could look at. Research utilization, implementation challenges, there's all these things. So definitely we want to get the best practices out there for what we're doing. Okay.
What is this? Sweet bread. It's really good, like toasted in the morning with like butter. You got butter? Mm-hmm. You got a knife?
Hey, Drew. Thank you. All right, so A1 also has perinatal quality measures. So they look at things like triage, health and wellness for women, care in labor, and also newborn care. So what assessments can indicate fetal compromise during labor? So obviously we haven't learned about all this stuff yet, but what's going to indicate fetal compromise is going to be fetal heart rate monitoring. All right, so basically out of this chapter, you need to get, how you can make a good decision about something that might be ethically wrong, you know, when you're taking care of a mother and baby. You need to be aware of that AWON and, you know, some of the things that they're focusing on. And then just look at all of those different um, things like, you know, the non-malfeasance and the fidelity and all that. Make sure you know those things. And then I think you should be good with this chapter. Okay, so we have one more, and I'm not going to go over it completely. I'm just going to go over part of it, and then you guys can look at the rest of it, and then we'll be all done for today.
Okay.
Okay, so this is chapter 3. So this gets into a lot about genetics and contraception and all that kind of stuff. So in this chapter, they discuss the relevance of genetics within the context of care of the childbearing family, identify critical components of conception, embryonic development, and fetal development, and they'll also describe the development and function of the placenta and amniotic fluid. They look at common causes of infertility, common diagnostic tests used to identify causes of infertility, most common methods used to assist with fertility, and then discuss the ethical and emotional implications of, you know, some of these things. All right, so genetics affects the childbearing family for sure. It's part of our job as a nurse to help counsel and support families with this. And then, I don't know, has any of you guys ever had to deal with anything genetically wrong in your family that you were concerned about? Like for me, I have an issue with my eyesight, and I was only born being able to see out of one of my eyes. So my other eye, I was born that way. I could never see out of it. So when I had kids, I was really concerned that maybe they would, you know, have that too. So not that we did any kind of like genetic testing or anything, but we've, you know, went somewhere right off the bat to get them tested right away when they were babies to make sure that they didn't have issues. So that's kind of what I'm talking about, anything like that. So here's a list of common genetic diseases. So, you know, for a lot of families out there, they may have someone in their family that has one of these things, and so they're concerned about it. So sickle cell, that's a huge problem for a lot of people. The African American community has a lot of people who have this. So there's certain people who are just carriers, and then there's people who actually would be able to get this. So sometimes it's better to have some testing just to know that right off the bat. Cystic fibrosis is another thing could be really bad. I know a family of people who they had twins, a boy and a girl, who both have cystic fibrosis. And so this was her second pregnancy. So the first pregnancy, that boy was fine. He didn't have anything wrong with him. So then they had the twins. They both had cystic fibrosis. And then she had another kid after the twins, and that kid is fine. So it's a recessive gene with that one. So, you know, maybe you would want to go through and do genetic testing to see. So there's a couple other things they mention here, but one of them I want you to kind of focus on a little bit more than everything else is PKU. Do you guys know anything about PKU? I don't know if you've ever heard of that or not. So with babies, when you have a baby, they will test your baby for this right off the bat. Let me see if I can share something real quick. There we go. Okay, so what this is, it's an inherited disorder that causes amino acid phenylalanine to build up in your body. So that's what this PKU is. It's caused by this defect in your gene that helps create the enzyme needed to break down that phenylalanine. So you don't have that enzyme, so now all of this phenylalanine can like build up in your body, and it can cause you to have all kinds of problems. So if you have this, some of the things that you might see, here's some of the symptoms here. So you can have a musty odor in your breath, skin, or urine. You can have a neurological problem that could cause seizures, skin rashes, or eczema. You can have microcephaly, hyperactivity, delayed development, psychiatric disorders, all kinds of stuff. So it can be like mild to severe with this. And so how you would take care of this then would be like you would have to watch what you eat from now on. So this person has to stay away from things that contain protein or have other things that would cause you to have a problem with this phenylalanine. So it's kind of crazy, but this is something that they test for, like right after you have a baby, they test them for this. And it's like a blood test that they do right off the bat. So anyway, that's that one. As far as the gene goes, it's autosomal recessive, I believe. Okay. So then this gets into a little bit about some of the ways things get passed down. So here's the autosomal recessive thing. So, hey, you have a dad that's a carrier and a mom that's a carrier. What are the possibilities for your kids? So you could have a child who doesn't have the condition and is not a carrier, or you could have children that don't have the condition, but they are carriers. And then you could have a kid with a condition. So 25% chance of getting whatever this is. If you have something that's autosomal dominant, this is how it goes. So now you have a 50% chance of getting the condition. So this also goes into, like X-linked and inheritance and all that, which I'm not going to get into all of that, but you guys can look through that. Something else that's important in this chapter I would want you to focus on is what a teratogen is. So a teratogen is something that is harmful to the fetus. It can affect development. So I don't know if you remember when you talked about certain things in pharmacology, and certain drugs are like pregnancy category, what was it, D or something, where you shouldn't have it because it's going to affect, childhood development. So things like alcohol, ACE inhibitors, anticonvulsants, cocaine, warfarin, even if you get an infection like a cytomegalovirus or, syphilis or something like that, Zika, from mosquitoes, any of those things would be considered a teratogen. Okay, so the next part of this just gets into some stuff that you guys can just read through. I'm not going to go through this part. I want to get to the stuff towards the end here. This talks about the placenta a little bit. So just be aware that the placenta hooks the mother to the baby, and you have an exchange of nutrients and hormones from the mother to the baby through the placenta. So it's really important. Excuse me. Okay, so this says, what structure provides cushioning and warmth to the fetus? It's going to be your amniotic fluid. So this would cushion the fetus from sudden maternal movements. It allows freedom of movement and provides thermal regulation. This is the stuff I wanted to get to towards the end because this is a little bit more important, I think. So a lot of times I'm sure we all probably know someone who's tried to get pregnant before that is having a hard time or can't. So there's all kinds of different reasons on why this might happen, but here are some risk factors for women who may cause them to have problems with getting pregnant. So if you've had pelvic inflammatory disease or a sexually transmitted disease or polycystic ovarian syndrome, I know there's a lot of women out there with that. Sometimes if you've had an eating disorder and you have poor nutrition, then you have a hard time getting pregnant after that because you have messed your body up so much from having this eating disorder that how are you going to support anything else, you know? Heavy alcohol use, obesity. If you get to be too old, that could be a problem. And then also diabetes. Those are some things that can really affect females when they're trying to get pregnant. And then if it's a male issue, it could be from some of these things. So prolonged heat exposures to the testicles, heavy drug use, environmental pollutants, impotence, advanced age, smoking, or sexually transmitted infections. So it could be some of those things. So when they're trying to figure out what the problem is, they would screen for some of those things, right? So they would look at sexually transmitted infections to see if maybe you had one of those. They would do some lab tests. They would do a semen analysis to see if you have enough. They would look at the women to see if they have any endometrial problems or how they are ovulating to see if there's a problem there. So some of the treatments that they do is to give hormones. So I know my sister-in-law, she had to take stuff. And then another girl I know, she was taking shots. So there's all kinds of different things that they can do. There's lifestyle changes and steroids and antibiotics and surgery. There's a ton of different things depending on what the actual problem is. So anyway, there is a lot of different assisted reproductive technologies out there that maybe people might be interested in if they're having a hard time getting pregnant. So as far as ethical dilemmas go, like say you choose a surrogate or something, a lot of people do that, and you have to have specific rules and things set in place so that you don't have a problem. Because what if this surrogate mother, she's carrying a baby for someone else, and then as she has the baby, she changes her mind and she wants to keep it, so you have to have things in place to make that be able to work. So there's a lot of different things that might come into play here. Risk factors for infertility include what? So it could be all of those things. So obesity, smoking, alcohol use, all of that. And then as far as this chapter goes, so the things I want you to be aware of, some of that stuff in the beginning about how you can get certain, genetic disorders passed down from, parents to their baby. So just have kind of a basic knowledge about that. Know about that PKU. I think that's a little bit more important than some of the other ones they have listed there. And then you can review a little bit of that reproductive anatomy stuff that they went through in there. And then the infertility stuff, know what puts someone more at risk for being infertile, and then know some of the things that they can do to help with that. In your ATI book, when you get that, there's a lot of that kind of stuff in those first 2 chapters that would help you. So that is it. Any questions about anything?
Are these chapter 2 and 3 PowerPoints posted anywhere?
I didn't yet. I'm having a hard time because she has voiceovers on these, and I'm trying to get it posted like I did the first one, but it just sits there and goes, because it's like such a huge file. So if I get my book today, I'm going to try and get access to all of the PowerPoints and stuff, and then I can just put a basic PowerPoint on there without her talking.
Thank you.
So you'll have it eventually. I apologize. I just didn't have it yet.
I have a question about ATI.
Yeah.
I was looking on there and the practice A and B, it says they're disabled by the.
Yeah, I need to get on there and enable it for you. Yeah, I just didn't do that yet. That's all. I can do that right now after I get off here. You guys are 1220 for your cohort, correct?
Yeah.
Okay, just so I'm getting in the right thing. All right, I'll fix that as soon as I get off here. And then for our next class, I put a thing in for 12:30, so we can all just get off here and go eat something or whatever, and then come back on and do our thing for that. Okay,
Sounds good.
all right, I'll see you guys in a little bit.